Hello, everybody. Thank you, Dr. Faiza, for this opportunity that you gave me to present one of the important issues relative to the woman reproductive health. I am Dr. Benabbou Amina, senior lecturer researcher at the University of Sidi Bel Abbas in Algeria, member in the Global Andrology Forum and in British Fertility Society and in the International Initiative IVF. The topic that I will present is Cesarean induced Isthmocel and infertility. The rate of cesarean delivery has increased dramatically and it has become a major driver in the total deliveries. This is not only in the developed countries, but also in the countries with limited, latest available data recorded between 2010 to 2018 from 154 countries covering 94.5% of world live births shows that 21% of women gave birth by cesarean worldwide, averages ranging from 5% in sub-Saharan Africa to 42% in Latin America and the Caribbean. So cesarean section has risen in all regions since 1919. Sub-region with the greatest increase were Eastern Asia, Western Asia and Northern Africa, while Sub-Saharan Africa and Northern America had the lowest rise. Projections show that by 2030, 28% of women worldwide will give birth by cesarean section. So, ranging from 7.1% in sub-Saharan Africa to 63.4% in Eastern Asia. Since 1985, the international healthcare community has considered the ideal rate for cesarean sections to be between 10% and 15%. Since then, cesarean sections have become increasingly common in both developed and developing countries. So, when medically justified, cesarean section can effectively prevent maternal and perinatal mortality and morbidity. However, there is no evidence showing the benefits of cesarean delivery of women or infants who don't require the procedure. As with any surgery, cesarean sections are associated with short and long-term risk, which can extend many years beyond the current delivery and affect the health of the woman, her child, and future pregnancies. These risks are higher in women with limited access to comprehensive obstetric care. So, in recent years, governments and clinicians have expressed concern about the rise of the number of cesarean section births and the potential negative consequences for maternal and infant health. In addition, the international community has increasingly referenced the need to revisit the 1985 recommended rate. So, World Health Organization proposes the Robson classification, which is a system that's standardized the assess or the monitoring and comparing cesarean section rates within healthcare facilities over time and between facilities. So the system classifies all women into one of 10 categories that are mutually exclusive and as a set totally comprehensive. So the categories are based on 5 basic obstetric characteristics that are routinely collected in all maternities. So parity, nulliparous, multiparous, with or without a previous cesarean section, onset of labor, if it is spontaneous, induced or pre-labor cesarean section, gestational age, if it's a preterm or term, fetal presentation, the presentation is cephalic or breech or transverse, and finally the number of fetus, if there is a single fetus or multiple fetuses. So the risk of cesarean section are many, and we note the major risk is an abnormal presentation. The placenta will be abnormal. It will be accreta or increta or percreta. The second risk of cesarean section is the uterine rupture. The third risk is the ectopic pregnancy, and the last one is the cesarean scale defect or isthmocele. So, when we talk about cesarean section, we have to talk about maternal and fetal complications. In this study, authors made a comparison of maternal and fetal complications in elective and emergency cesarean section. They conducted a systematic review and meta-analysis. All the cesarean sections are commonly carried out. They are neither minor surgery or nor without potential complications. So maternal morbidity is far higher with cesarean compared with vaginal delivery. This researcher concluded that emergency cesarean sections showed significantly more maternal and fetal complications and mortality than elective cesarean sections. So they reported that certain plans should be worked out by obstetric practitioner to avoid the post-operative complications. On the other hand, another research was conducted, a retrospective one, on 1,318 women who underwent repeat cesarean section between January 2013 and 2016. So the study was conducted to compare the obstetric outcomes of cesarean section in women who had a history of 4 or more previous cesarean sections with those who had a history of 2 or 3. So they concluded that although multiple repeat cesarean section are associated with adhesion occurrence, higher number of blood transfusion, increased operation time, and length of hospital stay, there is no remarkable difference in serious morbidity associated with multiple repeat cesarean section. So, the term isthmocele was first coined in 2007 to describe at ultrasound an anechoic oval-shaped area located at the level of a previous scare in the interior wall of the cervical channel. So previously, an isthmocele has been reported in the literature as a cesarean section scare or cesarean section defect, or a deficient uterine scare, or a scare pouch. So there was no precise definition or precise term to this pathology till 2007. Doctors gave this pathology the term of isthmocele. So at hysteroscopy, an isthmocele appears as a reservoir, like a pouch, defect on the interior wall of the uterine isthmus located at the site of a previous cesarean delivery scare. The best time to identify the pouch is between the 7th and 12th day of the menstrual cycle, because the reservoir is filled with brown colored blood, whereas the rest of the uterine cavity appears empty. So the trapped blood is slowly released, appearing as postmenstrual spotting, which is reported by the patient to darken with time. This may happen spontaneously or less commonly after coitus. This picture shows a cesarean scare defect, deficient uterine scare or scandescence following a cesarean section involve myometrial discontinuity at the site of a previous cesarean section scare. So this anatomical defect resulting from previous cesarean surgery have been reported to be associated with prolonged postmenstrual spotting and chronic pelvic pain. The second picture shows a longitudinal ultrasound image for a uterus, and it shows a myometrial discontinuity in the lower uterine segment. So concerning the classification of the isthmocele, some authors classify the isthmocele according to the size of the defect. It can be classified as a small or a large defect depending on the wall thickness of the myometrial deficiency. So the schematic drawing illustrates the measurement of cesarean scare defect. The width is the widest gap along the cervico-isthmic canal. The depth or the D is the depth or the vertical distance from the base to the apex of the defect. The thickness of the residual myometrium is from the apex of the defect to the uterovesical peritoneum. So when we want to talk about prevalence of isthmocele, we say that there is no exact prevalence, and it is related to the method used to assess the defect. In a recent systematic review, authors have found that the prevalence of isthmocele ranges from 24% to 70% in transvaginal uterosonography examination, and from 56% to 84% in sonohysterography in women with one or more previous cesarean section. So the prevalence increases with increasing number of previous cesareans. Current data suggests the development of isthmocele in approximately 60% of patients after a primary cesarean section and 100% after 3 cesarean sections. The symptoms of isthmocele in general, the most isthmoceles are asymptomatic, being found incidentally on ultrasound. However, over the last decades, with the rising rates of cesarean section, there has been an increase of sequelae reported after this procedure. Symptoms including abnormal uterine bleeding, postmenstrual spotting, dysmenorrhea, pelvic pain, and infertility are recorded in the case of the isthmocele pathology. The infertility is caused by the negatively influence of isthmocele on the mucus quality and on the hamper of sperm transport. It hampers the sperm transport. It interferes with embryo implantation, and it causes the endometriosis in 20% of cases, which depend to the depth of the cesarean scar defect. So all these symptoms are have now been related or associated with isthmocele. The obstetric complications of isthmocele were described in the literature, such as placenta accreta, placenta previa, scar dehiscence, uterine rupture, ectopic pregnancy, and in cesarean scar defects. So the risk factors related to the isthmocele are related to the suture type. If the suture is single layer closure or a double layer closure. They are also related to the patient when the patient is old, maternal age, when we take in consideration the maternal age of the patient, the previous cesarean delivery, the obesity, and the uterine reflection, and the last risk factor is related to the pregnancy when it presents a macrosomy, or when there is a gestational diabetes, or when the labor duration is more long, and if there is an infection in the female genital tract. Concerning diagnosis, there are no definitive criteria for the diagnostic of Isthmocel. Multiple imaging methods, including sonohysterography, ultrasonal hysterography, ultrasonography, hysteroscopy, and magnetic resonance imaging, can be used to assess the entire uterine wall and diagnose Isthmocel. Transvaginal ultrasound is the initial and most usual method described to assess the integrity of the uterus wall in non-pregnant women. The prevalence of Isthmocel is in sonohysterography when compared with transvaginal ultrasound appears to be higher, 56% to 84% against 24% to 70%. Nevertheless, the sonohysterography is more sensitive than transvaginal ultrasound, and the defect seems larger or deeper by sonohysterography. Therefore, the saline infusion sonohysterography is more sensitive and specific for the identification of Isthmocel. The hysterography can also assess the Isthmocel. However, it can't measure the myometrial thickness, which is a limitation of this method. Moreover, if blood or mucus is accumulated in the Isthmocel, hysterography may not clearly identify the defect. So, the magnetic resonance imaging allows determining the RM thickness of the Isthmocel. The hysteroscopy enables direct visualization and confirmation of the pathology. So, concerning the treatment, there is many methods for to treat the Isthmocel, and it depends on the thickness of the defect. So, in this research, entitled From Hysteroscopy to Laparoendoscopic Surgery, what is the best surgical approach for symptomatic Isthmocel? It's a systematic review and meta-analysis, and the authors found adequate evidence supporting the use of surgery for the treatment of symptomatic Isthmocel. as it was found to improve the bleeding symptoms in more than 80% of patients. Differently, they found a lack of evidence regarding the role of surgery with the purpose of improving fertility or reducing the risk of obstetric complications in women with asymptomatic isthmocele. So, authors reported that the hysteroscopic correction of isthmocele may be the safest and most effective strategy in those patients with adequate residual myometrial thickness overlying the isthmocele. Laparoscopic and vaginal surgeries may be the preferred options for patients with a thinner residual myometrium over the defect when it's less than 2.5 millimeter and when hysteroscopic treatment is inconclusive. So before choosing a specific surgical approach for isthmocele, careful pre-operative evaluation of residual myometrial thickness overlying the isthmocele is recommended. So we see in this flow chart for the treatment of isthmocele in women with abnormal uterine bleeding and infertility, patients with reproductive desire, the laparoscopic or vaginal repair of isthmocele may be preferred to hysteroscopic surgery, especially when residual myometrial thickness is less than 2.5 to 3.5 millimeter. So here to reduce the risk of bladder injury, and these techniques were associated with greater postoperative myometrial thickness compared to hysteroscopy. So patients with no reproductive desire, the hysteroscopy may be preferred to laparoscopic vaginal surgery for isthmocele due to lower costs and risks of surgical complications. The choice between vaginal and laparoscopic surgery should be individualized and must primarily take into account the expertise of the surgical team. So there is lack of evidence supporting a specific surgical approach for isthmoplasty when residual myometrial thickness is more than 2.5 to 3.5. So hysterectomy is the curative management for large symptomatic isthmocele in women who do not wish to conceive anymore. For the asymptomatic isthmocele, there is no treatment to the patients till the apparition of one or more than symptoms. And so to conclude our presentation, we can say cesarean section is not a trivial surgical intervention as most women think, and they wish to undergo it to escape the delivery pains. The health authorities must deal with this pandemic and reduce the use of cesareans to decrease the risk of isthmocele. Women must be sensitized of the cesarean section obstetrical complications and the danger of isthmocele on their reproductive health. Gynecologists must have good training on the type of suture suitable for the uterus to avoid isthmocele. And finally, sensitizing doctors and patients alike about this pathology, as we noticed through our investigations, the difficulty in diagnosing the isthmocele, which indicates the ignorance of young doctors. And thank you for your attention.